Hello, everyone. A very warm welcome to today's session on solving orodental challenges in small animals. Endodontic instrumentation and materials, a step-by-step guide to basic endodontic procedures in small animals. We are honored to have with us our distinguished speaker, Dr. Adarsh Kumar, whose insights continue to guide and inspire the veterinary community. I'm Dr. Vishal Sharma, a proud veterinarian and managing director of Oriheal Lifesciences. As a practicing veterinarian myself, managing two clinics in North Delhi under the name Pets Planet India Pet Clinics, I truly understand the ground level challenges, hopes, and responsibilities we all carry. Buy a vet for the vets, a mission close to my heart. It gives me immense pride to share that Oriheal Life Sciences has grown into one of India's leading manufacturer of veterinary pharmaceutical medicines. But beyond numbers, what truly defines us is our purpose. We are a company built by a vet exclusively to serve the vets. Everything we do, be it innovation, education, or support, is centered around empowering our veterinary community. Safe, trusted, and first in India veterinary solutions. Our product portfolio includes herbal medicines, India's first 100% safe, sugar free, and side effect free formulations, safe even for newborn pups and kittens. Nutraceuticals, pharmaceuticals, injections, and grooming solutions, all carefully formulated for better compliances and outcomes. Breakthrough formulations includes meropenem injection, ferropenem tablets, alprazolam suspension, tramadol suspension, furosemide suspension, metazapine suspension, and many more. A robust range of neuro, cardiac, ophthalmic, dermatology products tailored for small animal needs. Strengthening veterinary knowledge across India. Under the initiative Buy a Vet for the Vets, we have created one of the largest platforms for continuous veterinary education. Through regular webinars, we aim to spotlight advanced yet often unexplored topics like neurology, radiology, ophthalmology, dentistry, etc. And because we understand that knowledge remains the most powerful tool in saving lives, your support is our lifeline. Friends, this journey is only possible because of your unwavering support. Every step we take forward, every educational effort, every new product is fueled by your belief in us. We humbly request you to support us in this mission in whichever way you can. Even a small order, a word of encouragement, or referring us to a fellow vet, each gesture keep this mission alive. Ordering us is quick and effortless. Just call or text us on the number mentioned in the chat box. Our team will personally connect with you to take your order. We deliver directly to your clinic, no middleman involved. 100% all benefits and support go directly to you. Let's walk this path together to grow, to learn, and to raise the standards of veterinary care across the nation. Thank you for being with us today and for being part of this journey. Thank you so much. Here, I would like to say a few words about Dr. Adarsh Kumar. Dr. Adarsh Kumar, a distinguished professor of surgery and head of the teaching veterinary clinical complex at the Veterinary College Palampur. With an illustrious career spanning over 28 years, Dr. Kumar has made remarkable contributions to clinical teaching, research, and institutional developments. His expertise has been instrumental in advancing anesthesia and critical care, diagnostic imaging, dentistry, and soft tissue surgery. His international expertise includes a tenure as a visiting professor at the University of Tripoli, Libya, where he worked in the University of Equine and Companion Animal Hospital. Notably, Dr. Kumar pioneered the admit pin, a widely used orthopedic implant for managing long bone fractures in small animals. A fellow of National Academy of Veterinary Science and the Indian Society for Veterinary Surgery, he has mentored 38 postgraduate students, published 155 articles, and received 43 prestigious awards for his impactful clinical research.
Thank you, Dr. Vishal, for the introduction, and welcome to my last topic of the basic endodontics. And let me share the contents here. So, good afternoon, folks. For our last talk in the series of the veterinary dentistry, and this is a little bit advanced, and I'll talk to you about the endodontic instrumentation and materials, a step-by-step guide to basic endodontic procedures in small animals. And I would like to simplify the things because there's a lot of protocol issues with the endodontics, especially the RCT and the restorative procedures are concerned, but let's try to simplify the things. Okay, now, if we talk of the first procedure of the endodontic, and that is the root canal treatment. Now, I would like to talk about the endodontics. And when we say endodontics, that means that it deals with the cause, diagnosis, prevention, and treatment of this area. If you see my cursor here, this is the pulp, I mean the structure which is inside the tooth, and precisely which is known as the root canal and the contents of root canal. It deals with that, it revealed, if you talk of endodontics or especially RCT, we try to remove all these structures and we try to fill up the pulp canal in order to alleviate the pain and the condition. Let's have a more microscopic view of the pulp. Look at this, how this pulp look like. It's almost like a jelly kind of a thing, very tightly, adjusted in the root of the in the root of the tooth, and it helps in nourishing the dentine as well as the tooth tissue to remain vital forever till you die. So when you talk of the first procedure, that is the root canal, and technically RCT is known as the pulpectomy. That means we go for removal of the pulp. Why we need to remove the pulp? Either to salvage a damaged tooth or the infected tooth, or to repair it. One. And second thing is, the elementary aim is to reduce the root infection to a minimal level to eliminate a further proliferation of the disease like periodontitis. And it is much, much less invasive than the surgical extraction, which we have discussed in our third lecture. Surgical extraction is a bit of more invasive procedure than the endodontic therapy, that is the RCT. And of course, when you save the tooth, aesthetically pleasing to the owner, that is also one of the consideration in the modern day healthcare, or especially the modern day veterinary dental care is concerned. So, objectives, again, I'll try to narrow it down. So here you want to retain a non-vital teeth, right? You maintain the function of the teeth, like the chewing, protection, and the bite balance. Bite balance means the occlusal relationship between the upper and the lower jaw and the Caesar bite here, like this. Then you eliminate the symptoms like draining tracts or reluctance to bite because of pain. If there is some fistula, fracture, the pulp is leaking out, there is infection. So animal avoids chewing. So in order to have a perfect bite, we need to treat the root cause of the pain, right? Indication against when it is an irreversible pulpitis, opaque tooth. Can you see a difference between two tooth? This is a normal tooth and this one is an opaque tooth here. So just glow a light. So when you see it is, it is there, and you can see how the color has changed, right? This is the draining tract here, keeps on bleeding. And this is because of the excessive attrition, chewing of the hard objects. There is attrition of the tooth and the pulp cavity has been exposed. Or sometimes there is a twisting, avulsion of the tooth, and you try to refix the tooth, but eventually what happens, tooth remains there, but the pulp is lost because of the connection being lost at the apical forum. And in that case also we go for the RCT. So again, a very good example here. This is a discolored tooth, which is indicating the pulpitis here. This is the swelling, infraorbital swelling due to the tooth abscess. again a crown fracture of the canine tooth here, exposing the pulp here. You can see this black dot here, that is the exposure of the pulp. So we need to close this. Contraindications: if there is a root resorption, you don't find the PDL here, the periodontal ligament, which we discussed in the first lecture or the first webinar. You don't find the PDL here. So that means the root resorption is in process. If there is abnormal tooth root or there's a fracture, can you see a fracture here? So there is no fun of doing the root canal therapy in this tooth when there is a fracture of the root tooth. Okay, and when there is a significant periodontal disease, you don't go for the RCTs. Now, RCT involves majorly 4 steps. One is to access preparation. That means you access inside the pulp canal, then you debride the canal, and then you obturate the canal, and then we restore the canal. And mind you, my friends, this whole process needs repeated X-rays. So for doing RCT, X-ray is must. Coming to the materials, we have this root canal sealer, and root canal sealer we normally call it as Zoe. Zoe is zinc oxide plus eugenol, right? So in short form, we call it as a Zoe. It is a traditional root canal sealer. What happens is that when we mix them both together, they fill the irregularities between the root canal and the obturating material, and it provides a hermetic seal. I mean, the air watertight seal, which prevents the micro leakage and the bacterial ingress. Then, in order to have a disinfected or infection-free root canal, you use the sodium hypochlorite. So it is known as the root canal irrigant, right? The major quality of the sodium hypochlorite for the endodontic irrigation is that it dissolves the organic tissue, including the remains of the pulp and including the bacterial biofilms, which has somehow developed in the root canal, and thus it ensures a bacteria-free root canal system for the obturation. Then this canal is when filled with the gutta percha, and we call it as obturations. So we will slowly develop the topic here. So this is the gutta percha. So gutta percha, initially, when we talk of humans, the gutta percha is available in the form of these tips. We normally call them the gutta percha points, right? So they are standardized points, and you can put it inside the canal, but sometimes the canal is very large. So now these gutta percha, they are the tips, but now you find them in the syringes here. We call them a gutta percha flow. So this is a kind of a thermoplasticized liquid, and which can be poured inside the root canal, thus ensuring a complete filling of the root canal. So this flow enables superior adaptation and a sealing of the complex root systems, because it flows into the prepared canal and it occupies the canal very fine. So especially when you talk of canines here or the dogs here, the tooth root being a very large or a bigger one, the gutta flow is of extensive use, and it is very, very handy. These are the paper tips, and these paper tips are kind of blotting papers. They are very, they are wrapped up and they are compacted. You can put this inside the canal, so they absorb the residual moisture and thus makes the root canal dry. So drying, cleaning, and applying the medicament into the root canal is through the paper points. This is a usual irrigation syringe here. Ready-made syringes also they come, so you can flush the root canal. Sodium hypochlorite, let's say, you can always flush it with the syringe with adapter like this. You have many kind of tips. Some side vented needles are also there. If you have a side vented needles, they reduce the apical pressure, and it prevents the extrusion of the apical foramen, which has to be prevented. So direct pressure can cause the injury to the apical foramen. So we have the side vented needles, which can be used very well for this irrigation syringe. Now, a difference between the files and the reamers. Let's make it very, very clear here. Now, the upper figure indicates a file and the lower one is a reamer. Number of flutes per unit of the size of this are more in the files and less in the reamers here. Okay, now these blades are of the cutting nature. So when we put the K file inside the root canal, the basic function of K file or K reamer is to cut the dentine, and then it has to be taken out. So when you need to cut or you need to cut a more dentine in a highly compacted tooth, we go for the reamer first and then the K file later. And if tooth is manageable, you can do it with only the K files. Okay. Now, this is how the K file looks like. This is how the K file looks like. So these are the flutes here. So they are typically used with a sequential increment filing until you shave the dentine within the canal. I'll tell you how it is to be, how it is to be rotated. Then you have H files. Now there is a difference between the H file or the headstone file and the K file. K file is used for cutting, whereas H file is used for shaping the root canal. Now it has the flutes which are triangular in nature and towards the reverse side. So it helps in shaping and widening of the canal. Okay, let's have a closer look here. Now, this is a K file. Can you see the formation here? Here the formation, how the flutes are being arranged. Whereas if you talk of H files, it is arranged in this triangle. So when you push the K file inside the root canal and you rotate it, it will cut the dentine, right? Whereas when you put the H file inside the root canal, it won't cut. When you take it out, because of these blades, it will shape and widen the root canal. Okay, how to differentiate between two? So you see from the side here. Now, this is the side which is available here. So I'm catching hold of one file which is roundish, So when the square is there on the tip here, it is K file, and when it is roundish, it is H file. So you just can see from outside, if it is round, you can say it is H file. If the number is written in a square, then it is K file. Okay. Then comes the K reamer, which I was talking about. Can you see the flutes? They are big here. So you go for the clockwise turning movement into the root canal, right? And this will help in shaving off a larger area in the root canal. So the difference between the K file and reamer is that it is more flex. So Ni-T is the nickel titanium. Okay, sometimes what happens with the K file is that K file is a hard file, and if you go for the excessive rotation, it can break. Whereas nickel titanium file is flexible, it is super elastic, and it has a shape memory. So even twisting more will prevent its breakage. Once it breaks, it can cause problem. Okay, so there's a difference between the flex niti and the K file here. Okay. Then barbed brooches are there. Now there's a difference between the file and brooches. The file is different thing. Once you have cut the dentine, once you have loosened the pulp inside the cavity, these brooches are put inside to remove the root canal and the pulp contents. So brooches, they are inserted inside and they are taken out. So when they come out, they bring along with the pulp contents, which can be very well wiped on your hand. Okay, I'll show you the videos. Then you have these lenticulospiral fillers. See the spring type of the thing here, tip here. Okay. Now with the lenticulospiral fillers, you can take a eugenol, or you can take any, sealer. You can immerse this inside the sealer, and you can put it into the root canal. Okay. The function of spiral filler is to evenly and uniformly distribute the root canal sealer solution or the cement in the root canal. Otherwise, what will happen if you put it from outside, if you try with anything, a little bit of will go inside and rest will come out. But with the help of the lenticular spiral fillers, it will compact the root canal, whatever you are using, either cement or any kind of a solution. Okay. Then EDTA is a very common thing. So always when you use K files, when you use H files or use the reamers, always first apply the EDTA and then you go inside. The first function of EDTA is to lubricate the file, right? Then EDTA acts as a chelating agent. It removes the smear layer. It leads to the chemical softening of the dentine also. It increases the permeability of the dentine also, and it helps in early revascularization of the pulp tissue. Okay. Then the dental curing light cure. This is a UV light here. So a very small instrument which is available here. So when you apply this UV light to any resin-based material like composite, sealants, or the adhesive, this light polymerizes the light-activated dental material. So once this resin-based material is being polymerized, it gets hardens. So it makes a very good seal, a very good adhesive seal over the area where it has been applied. Only fundamental of applying the dental care or dental light is to keep the light away from the site 3 to 4 mm, and the time should be between 30 to 70 seconds. Don't apply more than 1 minute or 70 seconds. It can lead to a problem, or it can injure the dental tissue also. Then the dental composite material, they are available in different colors. You have an acid H here, you have a bonding material here, you have this brush here, you have the brushing tips here. So you can clean it with this brush tip and use it anytime. So aesthetic, that means you can choose the color of the tooth, and you can see the color of the tooth, and you can choose the color of the composite material. Now this composite material is very strong and it is wear resistant. That means it will withstand the abrasions. So it has a low solubility, so it is resistant to the oral fluids also. Then it has a handling, it can be shaped into any position. If the tip of canine is like that, you can shape it in a form of the tip of the canine. If you want to form a cusp of the molar, you can accordingly form it with the help of a burr, right? Then conservative, to enables minimal removal of the tooth structure. So when you have the composite, the minimal of tissue of the tooth is being removed. So you can just prepare it and apply the composite material over that. Now this is the spoon excavator. It is used to apply, used to clean the valves also. You can apply and for the, gutta also when you want to cut it. So tip being very small and a spoon shaped, so you can excavate the things from the cavity, from the pulp cavity, and from the prepared pulp opening also. Then the procedure again: assess preparation, canal debridement, then cleaning and shaping of the canal, obturation of the canal, and restoration. So excess preparation. Now, when you want to go inside the tooth, you have to cut the crown. So that is known as crown reduction or crown amputation. So you use these rugby balls here, or cross-cut bars. But if the tooth is fractured and you want to do the RCT, there is no need of crown reduction because it is already open. So for cutting, you need a high-speed drill. Now, once it is being cut, you have to go inside the pulp cavity. So for that, you need a slow speed drill. And this is the handpiece where these burrs, they are applied. So once the pulp chamber is exposed, that means there is access to the pulp chamber here. Just see here how and this is a opaque tooth. So this is how the crown is being amputated here, cut. Okay. Then we drill the pulp chamber like this. It is being drilled in a rotatory movement, very fine movement. And this is a pulp chamber access. The pulp chamber has been exposed for filing or canal debridement. Okay. So for canal debridement and preparation, I told you we are going to use the barbed broaches to take the pulp out, K file for cutting the dentine, H file for shaping the pulp cavity. So point which you should be remembering here is when you are inserting the file inside for the cutting here. Now this file will go inside. We call it as a balanced force technique. Okay. So when you've inserted inside, go 1/4 rotation and then you rotate 3/4 and then again come reverse and take it out. Okay. So when you are, this is the coronal part of the root canal and this is the apical part of the root canal, right? So this file will go inside as long as it is there. So there will be a 1/4 movement. That means it will engage the dentine. Then you go reverse for 3/4. It will disengage the cut dentine and third will separate it and fourth will take it out. So this is how the movement of file should be like that. So then once you go inside the root canal, you have to determine how deep you can go. Right. You just cannot afford to go right up to the apical foramen and puncture it. So you need to locate that apical foramen. So there's a term called master file. So when master file apical, when master apical file means that it will determine the final size and shape of the apical portion of the canal. That means that from the outside till you reach the apical foramen, 2 mm short, you have to place the endostop so that your file should not go inside. And whenever you are using a file, I told you, you have to each time lubricate it with the EDTA. I'll show you how. See, this is the final shaping of the canal. So I'm going inside, going inside, going inside, So that means it is reaching up over here. Okay. So once you reach the apical foramen, how you're going to confirm it? You're going to take the X-ray. Okay. You're going to take the X-ray and just 2 mm above the apical foramen. That means you have to stop. And you have to place this endostop 1 mm the total length. That means whenever you are going inside the pulp canal, you have to leave that much of a space. Otherwise, you can open up the apical foramen, which is not just desirable. Right. Now, for this, you have to take an X-ray and you see, determine this is somewhere the apical foramen is. And just 2 to 3 mm away from the apical foramen, you need this much of a length. So you can measure it from here and you can put the endostop just 1 mm behind the original tested length, which has already come out. Okay. So this is again a working distance which is being measured here. Now this is the canal debridement. See, can you see my hand here? I am putting this file inside, taking the H file outside. Okay. And then I am now rotating it, engaging the dentine here, taking it out back. And once it is being derotated and taken out, now it is being taken out. So pulp has come out with this file and you can see your hand. This is my hand has all this pulp which has to be taken out. Okay. Okay, fine. So in modern veterinary dentistry, you have the apex locator here. So there is one electrode which is attached to the file and one on the oral mucosa. The moment it reaches the apical, the most resistant, or most narrowest part of the root canal, it will show green, this thing. So that means you don't have to go beyond that. So that indicates that the endodontic file or the K file, H file has reached the apical constriction and you will find a beep. Okay. And there would be a green bar. Once the green bar comes, that means you have to stop. So this is the apex locator or electronically controlled apex locator, which can be used for this purpose. Okay. Now, once you have taken the pulp out, how you will know the pulp has come out? Every time when you will put it inside, you take it out and you rub your hand. If still the pulp tissue is coming, you have to continue the debridement of the canal tissue. And mind you, in younger animals, the canal is wider. In older animals, the canal is thinner. The contents are less. So for shaping of the canal, we will put this H file inside. This is the working length here. See, that's why X-ray is very, very important. Okay. Then you do the final shaping here. So here we can use this rotary endodontic motor also. So this is the final shaping of the canal. So that the access can be made so that you can obturate the canal properly. Okay. Now, there is a technique called step back technique. You must understand what step back technique is. Now, let us make it very simple. Suppose the master file is number 45 and it is going up to 34 mm. Right. So next file you are going to use would be higher than 50, but will go 2 mm less than the distance the master file has covered. Next time you'll go for a 55 less than 30. So you have to do at least 2 to 3 times so that you can reach up to 16 mm. Just have the example here. Now here the endodontic file is going inside. Let's say the apical file, the master apical file has reached up to 25 mm. So next is up to 20 mm and then see 30 number, then 35, 2 mm back, 45 size, 2 mm back, 45 size, 2 mm back, 50 size, 2 mm back, 55, 2 mm back. These are the numbers here. The idea behind using the step back technique is to prepare the root canal in the form of cone. So you can see a cone is prepared here so that inserting the gutta percha becomes easier for you. Otherwise, if it is not in the shape of the cone, your gutta percha, even the gutta flow will don't go inside. So this is step back technique where you increase the size of the file every time, but you are always going 2 mm or you are stepping 2 mm backwards, 2 mm backwards, backwards, backwards. Right. So in between that, you have to do a recapsulation. That means you have to put a smaller file inside to keep the apex packing from the dentine. So step back, apical half of the canal is reached. So you have to step back till you reach half of the canal, right? Suppose if working length is 34 mm, so you have to step it back. 34 means 30, 28, 26, 22 till 16 to 18 mm. So that will form a cone and it would be easy for you to obturate the cone. So you go for the final flushing of the canal with the normal saline and then with the hypochlorite solution, right? You can dry the canal from here. So you go for the drying here. This is with the help of the paper point. So let's look at here, once you dry it, this paper tip is inserted inside. Now this will absorb the residual moisture. Take it out, Again, use another tip till you find that tip is dry. Okay, and this is the final drying with the help of the air water syringe. So here you're only using the air. So then once it is being cleaned and it is dried, you take the ZO, that means the zinc oxide and eugenyl paste, and seal the cavity here. So put it inside. Now filler is by the lenticulo spiral fillers. So you can put this inside and you can seal the root canal with the help of ZO. Then the cavity is prepared, the pulp cavity is prepared. Now you have to obturate the canal. How to obturate the canal? You have to decide a master apical point. Now, master apical point is a point where you have to place a gutta percha. Now, the only fundamental is if the master file is, let's say, 45 mm, then the size of the gutta percha should be 40, little lesser than the master file. Okay, you're not going up to, canal is being prepared, but you're always using one size less gutta than the master apical file. Okay, radiograph the tooth with master point, remove and measure the point. Okay, see, look at here. Now, this is now the gutta percha. So this is the flow gutta percha I'm using. With the help of a syringe, I'm putting the gutta percha inside. Now here, there is a problem because this is a human adaptation and the tip is very low here. It is very, it has filled up. So the gutta percha is coming out. At the same time, you can go for the smearing of the root canal with the help of a lenticular spiral. This will evenly distribute the gutta percha. And you can at the same time also use a cone, gutta percha cone, and to fill it inside. That means you have cleared all the tissue of the pulp and you are packing the pulp with the help of the cone here. Okay, so gutta percha cone is again very small here. Now you can see the tip here. If slightly reverse it, can you see the tip? It is very small tip. It won't go inside. So I'll give you a a tip here. So just listen to video. So we have, so what happens is that this syringe has a gutta flow, and this is a tip which is available commercially. This length of the tip is very, very small here, right? So what we have done is, how we customize it, cut the tip from here, cut the tip from here, like we have cut this. Okay, I'll just show you. Uh, so this has been cut like this has been cut, it has been removed, and then mount it over the syringe, right? And then you have the flexibility of taking this 18 gauge needle, either blunt or sharp, and put it here. So from you can push it from there and see in this video, I am, reaching to the desired depth of the canal and putting this gutta percha inside. That means I am ensuring a proper packing of the canal. If canal is not packed properly, your RCT is half done. The job is not done. Okay. So once you pack it, I always try to pack or reinforce with the help of the cone here. So I put the cone inside. So cut it from here. So you just prepare it try to pack it here, you use the heated excavator here. Okay. And this is how the post-obturation canal is looking like. Inside is a gattaparcha, mixture of flow and the cone. The mouth of the cavity is sealed with the help of the gattaparcha. Now let us come to treatment of this particular site, how it has to be treated. Okay, look at here. It has gone up till here. Okay, so this is complete obturation of the canal, right? Up to the master apical point, just 1 mm away from the master file. Okay, then final restoration, we got to use this glass ionomer. The function of glass ionomer is to form the adhesion, release the fluoride. It has a biocompatibility and the antimicrobial properties. So this glass ionomer is applied over the dentine, the area which you have prepared and light cured. See this video. I am applying now this is the glass ionomer which has been applied on that open, prepared, obturated cavity. This is restoration. And then once it is being restored, so this is the crown preparation. Slightly take a burr and very mildly roughen the area around that cavity, right? And then you apply the acid etching. This is the acid etching I am applying over this. This acid etch solution comes in the composite kit. Okay. Then once the acid is being applied, wait for 30 to 60 seconds and then rinse it with the water and dry it with the air. Okay. Then once you have dried it with the air, you have to go for the application of the bonding resin. So this is how a bonding resin is applied on that tip. So that means now this tooth is now having a bonding resin to accept the composite. So once you've applied the bonding resin, you have to go a light curing of 30 to 50 seconds of the bonding agent, right? And then comes the application of the dental composite. Take the dental composite out of this, the syringe, and then you apply over the tooth. Okay. Now, once it is being tightly packed, light cure it. So this is light curing of the dental composite for 60 seconds. And this is the, sorry. So this is the final look of the composite here. Now you can remove, once you light cure it, it becomes as hard as dentine is. It is cemented, it is adhesive, it adheres to the dentine like anything, becomes very hard. So then you can shape it with the burr. Okay, look at here. Once it is being shaped, sorry. So you can shape it with the burr. Once it is being shaped, so you can do the polishing here. So that is the polishing. So you can polish the edges to become a smoother one. Okay. And it retains for a long period of time. So this is how the polishing is being done. This is the final appearance after the restoration of that tooth. Okay. And that is the outer composite, and there is an inner gattaparcha. So that is the post-operative X-ray of the root canal treatment, which is a final X-ray. So see here. So here is a composite which has sealed the mouth of the pulp cavity, and the pulp cavity is sealed with the help of the gattaparcha. For the canines, you have a problems. Canines are long, so you can access the canine partially from here also and partially from here. So you can create a hole from here, right? So your file can go from here. Otherwise, there is always a bend, canine is like this. So from here, when you put a file inside, it will stop here. So that's why you have to prepare another hole from here, and you can go obliquely also up to the root. So this is how the cavity is being prepared from both the sides, from the apical and from the lateral border also, and from the occlusal surface. Okay. So two holes, one here and second here. And once you put the guttapercha inside, you can go for the composite material application over this side. So this is the final restoration of the tooth. Hardly that holes on the occlusal surface as well as on the lateral surface is visible to you. So that is the canine. See the length of the pulp cavity, and whole of the pulp cavity is being obturated. So that was the RCT in a simpler form. Another very short procedure is the tooth restoration, because every time you cannot do RCT. Okay, so tooth restoration is very simple procedure. Same thing would be repeated, but let's have a recapitulation and relook at this. Indications. Can you see this keratotic lesion here? Now, that means the pulp is going to be exposed. Before it exposes the pulp, you have to seal it. You have to restore it. This is also an area which is of a questionable viability. So this has to be curated and restored. Okay, so you have three major steps. One is the preparation, another is the filling, and the finishing, as you do in the humans. So first of all, this is the physical examination of the tooth. You can see this is a attrition tooth. Okay, so you take a radiograph, see the PDL integrity. So PDL is integral. That means you don't have to go for the extraction. You can go for the tooth restoration, or you can go for the RCT. So pulp cavity is good, right? So there is no pulpitis. So you can restore the opening here. So this opening can be restored. Okay, I'll just show you how. So first thing is you have to create a 45-degree bevel around you have to prepare or freshen up this area. Look at this. I'm using a football or diamond bar here. Just cleaning the area, all that blackish tissue and blackish dentine in this color has to be rubbed off, shaved off, and the bed is being prepared. Okay, then you irrigate it with the help of a mist. Okay, then you acid etch it, apply the acid etch on the crown, then you rinse it and blow it dry. After etching, you go for the application of the bonding agent here with the help of the brush. Once the bonding agent is being applied, you have to go for the light curing for 30 to 60 seconds. That will harden the bonding agent and prepare the bed for the application of the composite, right? Then comes the filling. Now here a flowable composite is put into the excess hole. And whenever you are putting the composite, slightly use a bigger quantity or a larger quantity, because you can then you have the flexibility of shaping it according to the shape of the tooth here. Okay. So this is a syringe. I'm taking this composite out from here, applying it over here, right? Now this bed is already prepared with the bonding agent. Once I apply this hybrid composite over here, it will stick over there. But then you have to light cure it for 60 seconds. The moment it is light cured, it becomes very pucka and hard. Okay, then comes the finishing. See here. So I am now finishing the composite here. I slightly carving it out. We call them a carving of the area according to the shape, so that shape is good. It should not have a bouncy this thing. And finally you take this x-ray. The pulp is good inside, and this is the final radiograph of the composite or the restored tooth which is there. So a very simple procedure like this. So then you irrigate the finely restored tooth, and Once you have restored it, washed it, it is always having a rough surface. So it is always advisable. I told you while we were dealing with the periodontal problem is that once you do a dental job or a cohad, you must polish the tooth. Once you polish the tooth, that means you will soften the surface. So that will, you know, that will not that will allow a good gliding movement over the tongue and will have a good occlusal relationship in a very soft manner. Okay, so that finishes the oral restoration. I won't go into much detail, but what we have done and how far we have reached, I'll just tell you in the next slide. That's this tooth. If it is looking like this, let's say, if it is looking like this, you can go for the crown like this, that we have done a crowning here with a nickel titan chromium crown here. So it again is a big is a quite a lengthy procedure. We have applied this crown over here. Now this is the picture on the day one. This is the crown after 6 months, and this is the crown after 13 months. So you can see it is very well adapted by the animal. So all in all, endodontics is important from the aesthetic point of view. You need to preserve the tooth as long as you can. Otherwise, you have a choice to go for the extraction, but if you can protect not even the non-vital tooth, endodontic has a great application. So thank you for your attention. So with this, I finish.
That was a great session. Let's see if there are some questions in the chat box.
Okay, so it is bit advanced actually.
It is bit advanced, and I think people will learn while doing this thing.
I hope so, because what happens is that we're reading books and simplifying into the step becomes an issue. But it is a doable thing. Especially my message to the veterinarian is, please start from the oral restoration of the tooth. Later you can graduate to the endodontics, that is the RCT. So in a way, it becomes very important. Although it is a time-taking procedure, it needs a patience, but patience pays.
So actually, the future is all about the specialty only. As the competition is rising and standard of the practices are rising, we need to have the specialty clinics. And I think I attended a few years back a seminar on, there was a vet from Denmark. So he's a basically dentist in the Denmark, and he has got a dental specialty only. So he was telling us that his one session, this consultation is $1,000. His consultation was $1,000, and he was seeing only the super premium clients. They used to come with their dogs, and the 2, 3 sessions and 4 sessions they take for the RCT and other things. And was a detailed. I mean, they are doing more than a human. This thing, 3D imaging and everything for the dental thing. So this is I think the next edge things are there yet to happen in India.
I congratulate you also for for chipping in for introduction of such topics to the Indian veterinary practice. There's a question from Urfai. Yeah. So what is the usual time for the tooth restoration? Urfai, the usual time for tooth restoration is, mostly when it is a fracture, you deal it as early as possible. Taking out fresh pulp is much, much easier. One thing. The other criteria is always look for the PDL integrity. You should not have the apical lucencies. So if PDL is there, it is intact, you go for the RCT if pulp is exposed. So don't wait for a longer period of time. You can wait, but why to wait? You do the procedure as early as possible, because once it is infected and somehow if it crosses the apical foramen, then you have the tooth is lost, and you have to go for the extraction. Is there any hand-on practice program for canine distillery? Dr. Vishal would like to tell this.
We are in talks and we are planning something like that, or maybe it will come up in another 1 or 2 months. Yes, we are planning for the dental hands-on session.
Yeah. So
And
Nikita is
only Dr. Adarsh will be taking all these things together. We will be, I mean, we are discussing and planning, but it's not easy to arrange any hands-on plan. So stay with us, and definitely we are planning for that.
Yeah.
Yes, sir.
So Nikita is asking, what is the treatment option for excessively overgrown canines? Nikita, you can very well go for the filing of the canines, and so once you file it, you can go for the restoration. Like I told you about the packing of the cavity with the packing of the cut portion with the help of the composite. So that gives you, if they are excessively grown, and if you happen to cut the pulp cavity also, right? You can seal it with the laser and you can go for the oral restoration, tooth restoration therapy. Or else, if it is very pricey animal, if you are going for the, cutting the canal or the root canal, I would suggest you to go for the RCT. Packet, it is one time it is being done.
And
So
definitely after
Indiraja
that,
is
there won't be any sensation after that.
no, once
Restoration of.
once it is being packed, that means the animal is in a comfortable zone. There won't be any pain. So pain is a major thing.
Yes.
So Selvaraj is asking, we do 3-layer filling in our sloth beer with hypo, cal plus. Yes, you can do it. You can do it with this also. I was trying to simplify it, because there are a lot of other solutions also available. But yes, you can do it with the hypo, cal plus glass ionomer and amalgam also.
Good evening, sir. Am I audible?
Yeah. Please tell me.
Sir, I just want to ask why we are making two holes in canine teeth. We can either approach from lateral one.
See, so from the lateral one, if you are not going from the apical side, how the gattaparcha will go towards the upside from the hole? It won't. There is an angle. And there is a reason why you are opening up the excess from there. Because either sometimes there is a fracture or anything, so apical is always opened. Okay. So just to have the excess and canal debridement from all the sides, you cannot debride upside. So the straighter length from the occlusal surface and the angle with the lateral side. You need to debride the root canal properly. If you don't debride it, you cannot obturate it. That's why you create two holes.
Okay, thank you, sir.
All right.
So one more doubt. I was not able to understand that endostop 2 millimeter above from.
See, you suppose the master file or master apical file is number 35. You measure it with the help of a scale and you arrange the endostop, or you can fix the endostop 2 mm away from the master file, so that you should not enter while you are going inside. You should not enter inside the, suppose this is the endostop here, right? So if the master file is somewhere over here, okay, somewhere over here, so you go 2 mm away from here, okay, fix it so that you are at a safer length to the apical foramen. Okay, bring it closer so that you have this endostop coming over here and restricting your movement, going inside the apical foramen. Correct? Just read it, you will come to know.
Okay, thank you, sir.
And you all are using human instrument. Do we have specifically? Yes. So this is the human file, which is 30 mm, and this one is the veterinary file, which even goes up to the 80 mm, right? So canine you cannot go, for molar, yes, you can do, but they're very hardy. So you have a larger files. So IM3 is selling them. So then how do you detect the apex? I told you you can detect it by the serial radiography, or you can have the apex locator. This type of instrument like RCT is expensive. How much? I don't know the price right now. But yes, you can contact the vendors. If no restoration is possible due to lack of facilities, is extraction of overgrown canine is the only option? Yes, then you can go for the canine. But I tell you, then, if you do not open the pulp cavity, then you can easily stop it there and file it with the help of a dental filing. But once you've opened the pulp cavity, you have to restore it. Correct. Sir, for RCT, we can either remove the enamel or make two holes. For the RCT, we can either remove the enamel or make two holes. No. I couldn't understand. For RCT, you have to create a hole. If you're talking about canines, yes, you need to make two holes because you have to take enamel is outside. You are cutting the dentine inside with the help of the files. So scaling was not a topic today, but yes, you have to go for the NCCR only if you want to do a perfect cleaning.
Yes. So I think this was the last question, sir.
Yeah.
So today I would like to know, sir, how was your experience having these sessions? How do you feel that way?
So I think you may be in a better position about the feedback of the things, but I think there are certain things, there are certain fundamentals which need to be looked at and have to be simplified. And the online teaching gives you at least an introductory window. It cannot replace the hands-on practice. But definitely it gives you a kind of idea how to go for it, because I try to always include the videos, and seeing is believing. Once you see the things, then you read it, and then you are in a position to do it also. So I feel it good, and it is a good initiative by the pharmaceutical companies, for chipping in for such kind of practice. And I would like to say here that if you are continuing with these platform, kindly extend these platforms to a working or a workshops.
Yes, sir. Yes, sir.
So that
Yes,
we
sir.
can converge
Without
on
that,
it.
this is incomplete. This education is totally incomplete if we are not carrying this thing.
Yeah.
The only thing is, sir, dentistry is almost unexplored in India, and you are the pioneer who's doing in this field. And most of the clinics only this dental cleaning is happening. Nothing more than that, or dental extraction is there. So this is a very good subject, and I think this is also again very good business in veterinary practice if we learn properly doing this. So my effort was just to create a interest in this particular topic. Many veterinarians attended this series, and when it is on YouTube, many people will again whenever they are free, they like to see all these things. By 2 times or 3 times learning this thing, then they have the full idea of doing how to go ahead with that. And when we club the hands-on things with this knowledge, I think the 360 degree of the knowledge is delivered, I believe. So these sessions were just to create a interest in the topic. And let's go ahead. And this is a long story, sir. I know this is a years-long experience you have in this field, so it is not possible to deliver everything in 4 hours or 3 hours.
There will certainly
journey.
be some gaps.
Yes, and it is a journey. It is a journey. We have to learn it by doing. So thank you so much, sir. On behalf of all the attending veterinarians and Oriheal Life Sciences team, thank you so much. You have done a lot for us, and you are really doing a lot for this community. I have seen your schedule. You are so busy with the college, your personal schedule, your charity works you are doing in your community. You are doing 24 hours, you are busy. and still you had a time for us. Thank you so much. Oriheal will always remember this thing as a, ehsan on us. And this is your and my duty. I mean, I would pursue you for this dental hands-on thing, what we discussed even yesterday, and let's make it practical within a time of 1 month or 2 months, sir. And this session was really, really informative, sir. Even I don't do all these things, but just by learning, I know how to educate the client, what can be done in this thing. And if I want to refer it, then I know at what stage what can be done and where I should refer this case, to whom I should refer. So this is going to help us a lot. Thank you so much, and looking for hands-on very near in future, sir. Thank you so much.
Thank you, Dr. Vishal. It is an honor and always a pleasure to be with the learning veterinarians and and associated with you also. So thank you, guys, and thank you, folks. Thank you so much.
Thank you so much, sir.
Most trusted pharmaceutical company for companion animals of the year goes to Oriheal Lifesciences Pvt Limited, Dr. Vishal Sharma from Oriheal Lifesciences Pvt Limited.